we've got plenty of time. I'm going to kick us off with a couple of questions. We have half an hour, so we'll have plenty of time if you can start queuing up your questions. And I'll get us started around what policy, practice, payment changes would help. I mean, so you all are doing this. You mentioned CMMI in some cases, actually in multiple cases, CMMI funding or kind of external funding to get it going. What are some of the changes or environmental factors that would help you sustain, flourish wherever your stage is, to think about that over the long term?
Can I start? And then, okay. So one of the challenges that I didn't talk about, because I was hoping somebody would throw a question my way where I could bring it up, is the issue around the revenue business model for dual eligibles. So we have, our dual eligible population is primarily under 65 and disabled due to mental health and behavioral health conditions. And we're not in a dual demonstration program. And the challenge is that we are losing, we're working with a very, very difficult population that's dying 20 to 25 years younger, very acutely ill with a lot of behavioral health comorbidities on top of medical comorbidities. And the STARS measures and the way that the revenue works with Medicare do not sufficiently account for those non-traditional physical health challenges. So we do okay on our over 65 population around the STARS measures. And as most of you know, that's how revenue is calculated for Medicare populations. It's the under 65, and we just happen to have a whole lot of them in our 11,000 duals population. So that has been a huge challenge for us, and one of the areas we're advocating for change with CMS, but it's hard because this is a national program and we realize we're only 11,000 of millions.
So everything I say here, I want to say we're in intense conversations and collaborations with our colleagues at CMS and our Mass Health program. Tim Engelhardt, who runs the Medicare Medicaid Coordinating Office, I should point out, has been a partner every step of the way. So what are those things? We feel Medicare risk adjustment is reasonably good for seniors. Not perfect by any sense, probably dementia in a few areas are underpaid, but by and large works. We have real questions that we, policymakers, academics, and leadership at CMS have about whether the HCC system, diagnostic system alone, adequately covers the costs of people with serious mental illness, people that Rebecca is talking about that we have also in large numbers. A lifetime of trauma, intermittently homeless, in and out of county jails. There is a sense clinically that social determinants and everything that's been said is required as an adjuster. So that would help to finally do the work to align payment, not just for, as we believe and as others believe, and as work is happening, by the way, at CMS. That would be a big help if it comes out the way we believe it will come out, and we are waiting that. So we see that as a big help. One other area for us in the same population, I think our learning as the first mover in the country is that we really need to build capacity for these challenged under age 65 populations with complex issues related to substance abuse, mental illness, homelessness, et cetera. What we found that there are whole populations, as I mentioned briefly, that we just can't contract with a primary care network or wrap it or enhance it as we do with seniors. We have to build it top to bottom. And now we have practice sites that we've had to build out in 4 different geographic locations in Massachusetts for people with very involved physical disabilities and developmental disabilities and serious mental illness, where psychiatry is integrated with primary care. We can't find it out there. We can't manage it. We can't find it. We have to build it. Nowhere in payment has there been the startup money. We're kind of undercapitalized nonprofit. We have to invest in all of this. And if we have to invest in it in Massachusetts, then it seems almost certain that others would have to invest in it. And so, so that would certainly be this issue of the recognition that there needs to be a capacity building. And I do want to say that part of the learning that we're learning together with our colleagues at Mass Health and CMS about what we're finding, and hopeful that we are going to be moving with some of these two. So those are two. I could go on to another laundry list of 10 others, but I'll stop here.
Well, just sort of speaking off the top of my head, I'd say there's a handful of things that we may have seen in deploying our program in the Medicare fee-for-service population. One is just simply that Medicare payment rules don't cover much of what we provide. I think the chronic care management codes and the transition of care management codes are a good first step in the right direction. But I know at least one person in this room who would say, and many people are smiling like they're the one, who would say that they don't cover the robust services that are really needed to care for this population. Likewise, the care coordinators and the data services and supports that we're providing, a standalone practice can't build that with an $8 to $40 PMPM or just some sort of per member per month based care coordination service. Medicare also doesn't include Part D, not only in calculating their savings target, which we think is how many people get the bulk of their care today, and it's often an early canary in the coal mine in terms of what's going on with that patient or not happening with that patient, but also timely access to Part D data is really helpful in sort of doing care coordination planning, and in many instances that's not always readily available. I think CMS has hinted at a number of other things in recent guidance or rules about things that they want to test about the use of financial incentives and other beneficiary engagement techniques. We currently waive all cost sharing for all medical services for our PCMH members who are adherent with their care plan, as a way of encouraging them to continue to engage with their care plan. And we may or couldn't not be able to do that in the current Medicare model as we know it. And then again, just getting timely access to data and being able to use that, not just at the Medicare level, but some others described earlier this morning, the challenges of doing that across states. So there's just some immediate reactions.
I just know that at this point in time that would help. I know that at this point in time with Medicare CCM codes and with the payment methodologies that's set up in Minnesota, it's caused a lot of confusion and some angst, probably would be a good word, amongst people trying to implement the system and to implement two different systems. So I think that has caused some of the clinics to really step back for a moment, probably, from some of the billing, rather than to go ahead and to bill for the services. So I think that would be one of the things that I would say is probably most problematic for them. And, as the Minnesota Department of Health, we're not, we're the face of the program. We're not, we're not essentially perfect billers or coders or things like that. So, we tend to refer them back to the source for guidance on that too. So that would be my take on it.
All right, I think we've got a queue, so I'm going to turn to the audience here. We'll start.
Hi, I'm Leslie Kelly Hall from HealthWise and the Informed Medical Decision Foundation, and also a consumer advocate. And I'm struck by what we've heard today. We've seen different models reacting to the community of need. It might be one that's founded in risk-based financial model, one that's founded in government, one that's founded in nonprofit, or one that's founded in a provider trying to do the right thing. And I think that this is a very, very good opportunity for us, perhaps in these findings, to say, what does your community align most with? And here is a menu of offerings that could be considered. However, I'd like to get back to two questions that were posed this morning and muddy the waters. One was by Deborah Ness, and one was by Catherine, and talking about building from the ground up. And if you'll bear with me just a second, today we just had a lovely lunch, and I'd like you to think about that lunch for a minute. And then I'd like you to think about if you were to design a lunch today, and it should be based on the best experience you would want with the constraints available to you. What would you be thinking? What would you be doing? What would you be feeling? Then I'd ask the people that provided the lunch, would you design lunch differently had you known these things? The answer would be, of course. So we need to ask those that we serve, what would you like to be thinking, feeling, doing, and what's the experience you want for each process we're designing for them, for each encounter we are expecting to provide, and each measure we're expecting to have success based upon. And you will find that what is designed is completely different from what we propose, regardless of the wonderful intention and great mind trust in this room. And I think that we underestimate the experience of the patient as informing the design principles of our work. So it's my begging. Thanks.
I don't know if there's a question there or not.
Well, I mean, let me try to phrase for a question is the role of patients in designing your program and co-creating it, where you get feedback, how, and even the more fundamental question of how much do you feel that your system is catered to making the current healthcare system work a little bit better versus, this is closer to what our ideal for our populations would be. So just kind of, I think, reflect upon that, how big the gap is, and then your process to address some of those fundamental questions.
I actually feel the core learning, the part of the DNA of our organization and the part of my own personal professional DNA over decades has been informed by our relationship with our advocacy community. And it goes back, in my case, to the early 1980s when colleagues at the Boston Center for Independent Living were finding that all of their goals toward moving toward independence and autonomy and self-reliance and self-management were being subverted by a medical care system that required them to be dependent and over-reliant on emergency rooms and impersonal care. And approached myself and other colleagues, I guess we were children of the 60s and trying to do different types of medical practice in our inner city communities, and had an idea about what it would look like. And they designed it. And it was, wait a minute, if I get an appointment to a clinic, if I don't feel well, I got to wait 48 hours for the ride. I'm going to end up, the only way I can get to something today is an ambulance in an emergency room. What kind of sense is that? So the idea, whatever we do, we've got to have an elastic system that comes to the home. I need personal assistance that is absolutely tailored to my needs, and it isn't necessarily Medicaid with the best of intentions. 5 minutes for combing the hair, 10 minutes for dressing, 15 minutes for, they have to do it from a distant, impersonal public bureaucracy. Isn't it better to have clinicians empowered or not, a team empowered with the person to determine what is the array of support services that is best tailored there? Those are two examples, as well as continuity through the terrifying hospital experience and on and on. Those were all examples that came in our world that led to the design, funded and clawing money from foundations to test it and evaluate it, and then eventually informing the entity that I work for today, of which the very same people are on our board of directors. And when things don't work well, you bet we hear about it and know about it. So that's our personal story. And I personally, and I speak for others that are on the clinician, and I hate the word provider. I hate it. I hate the word consumer, provider. I hate all those. But as other clinicians, our lives have been immeasurably enriched and inspired by this relationship. I don't know how to say it any other way.
Yeah, so I think that's a really good question, and our journey really started after many years of working pretty deeply with our members and our patients, and then taking a trip to Boston and hanging out with Bob and his teams, and then going to Camden and hanging out with Jeff Brenner and his teams, and then coming back home and saying, okay, so those are two programs that have good outcomes. They have been doing this longer than we have. We learned some really valuable key principles from both programs, but the very next step for us was to talk to our patients and our members. And so we did, when we went to their homes and we talked with them about what their needs were, where they were struggling, how the current healthcare system didn't meet their needs. And what they told us, in a nutshell, is that I don't need any more medical care. We actually have relatively good access, primary care access in Portland, and in Oregon, if you compare it, for instance, to Camden. So our patients, our members were actually, they were seeing their clinicians. They were in the clinics. And so they said, don't create more medical care for me. What I need is I need a partner, and I need someone to help me, really make sense of all of this, help me knit things back together, and someone who I can trust, who levels the playing field. And so that's how we designed really with a lot of feedback from we call them clients. I can't seem to find the right, we're still struggling with the right word. So I think that's a really important principle behind the way that we've designed. The other thing that's really important is it's a completely voluntary program. And that's been challenging in some of the practices that we work, because we have busy clinicians who, want to give everyone that they feel needs this program access to it, and they're not all ready. They're not all ready to take that step, and so we walk alongside them, and often they come back around and want our help at a different time. But it's never forced on anyone. It's very much there when they choose to access it.
Sure, thanks, Peter. I think the only appropriate answer to that question is we can always do a better job of listening to and learning from patients. That said, I think our program, which was most likely built on the principles of how medical care is paid for and how risk is identified and calculated, has really evolved over the years through the input of patients. And I think the effect of that has changed our terminology, it's changed our incentives, it's changed how we communicate with people. One of the more interesting things I've heard that the care coordinators do is in addition to arranging care and helping people connect with community resources, is actually setting up the conference call and sitting with our customer service representatives to help them understand their benefit structure. So it's not just that they don't understand how care coordination works or why they should see a certain specialist or not. It's how does insurance work and what is the role of all this. So I think that the input of the patient has helped our program grow and helped us become even better as a payer.
Okay, we have a question online. When someone wants to read, Minna, are you going to read or someone going to read the mic?
We have a question from Dr. Stephen Summers. Stephen asks, given that better health for this population depends on social determinants as much or more than healthcare, how are the panelists integrating social services on top of their integrated physical and behavioral health and long-term supports and services?
You guys are getting all the easy questions today. We'd like to take, let's try to do one or two responses so we can get to all. We've got quite a few folks. Let's try, yeah.
Within our program, we actually, alluded to this a little bit earlier, that we're not prescriptive, but we do talk a lot about health equity and how there is a recent health equity report out for the state, and it does show that there are some gaps. And so we are adding that to all of our policies too, as well as it's kind of an evolution with the clinics. The first year they do a partial, the odd numbered standards, and so they're building their foundation. The second year they're adding the even number standards, so they're actually adding more complex items or ways of doing things to that initial foundation. And it seems as the clinics move forward with this process, they're starting to recognize how they best can impact that care. And I think that every clinic, or most clinics that I work with, depending on the population served, will tell you that the social determinants of health are a priority. And if they truly are not meeting those needs, they will have a very, very difficult time being able to impact the condition that they're trying to help them with. So I think that it's really important. I think it's something that we provide education on. It's something that at our learning collaboratives that we have, that we bring in experts on social determinants of health. We've also, I know several of our clinics, just off the top of my head, are talking about they've been trained in trauma-informed care, so they're using that. And I would say the majority of the clinics are also using motivational interviewing to try to get to the bottom of some of these issues.
Let's go here in the center.
Hello, the microphones are always higher than I am because I'm so short. My name is Egondu Onyechekwe. That's a Nigerian name. Most people call me Ego. Don't call me Waffles, then we'll be in trouble. Just call me Ego, E-G-O, that's what you remember. I'm a doctor of a different kind. I'm not a physician. So, of course, I'm going to throw a wrench on this discussion. I'm an engineer by training, software engineer. My PhD is in information systems. Information systems, how do we collect data, distribute them, inform, and all that? So I have a two-pronged question on routes that I want to address. People have talked about social determinants, talking with teams and all that. Everything I've heard today inspires me because I didn't know them before I got here. But also they pose tremendous questions to me about sustainability, scalability, spread that Dr. Long mentioned earlier this morning. Oh, by the way, I didn't say what I do. I am an associate editor of a journal, Network Modeling and Analysis in Health Informatics and Bioinformatics. And I'm also on the editorial board of Springer Publishers. So that's where I'm coming from, not coming from the medical realm. Okay, so two prongs that I have seen. One comes from data, aggregates of data, all of data, from the structured and unstructured data that constitute what we call big data. Big data analytics in healthcare should be applied to almost everything you guys are doing, from the social media that we're using conversationally and other kinds of things that we can aggregate to measure really what the social or other determinants are for the patient, but I don't hear anybody talking about them. And in big data, we're talking at least 4 different V's: the volume, the veracity, helping the patient to protect the data, and also privacy. Yes, that's the one I forgot. Privacy, which brings me to the second prong of the question, which is, what is it that is the common thread for all of you, plus all of the other people in healthcare? To me, as a patient, it's me, the patient. And therefore, it is what I bring to bear in that setting, which is my medical record. All patients' records should be electronically documented so that they include pharmacy, laboratory, emergency, nutrition, and outpatient and inpatient care. so that when a doctor pulls it up, he or she is seeing me at a glance, in full glance. I've lived in 5 states in this country, and my records are scattered all over the place. And wherever I go to, I start filling out forms again. And I don't remember the diseases I had because some of them are gone. Anyway, I'm done. Those are the 2 areas I want you to think about. I want a situation where we create electronic medical records that are portable so the physician can have it and the patient can have it, and both of us have access at the same time. The physician is empowered, the patient is empowered, and we can discuss my health. Thank you very much.
Thank you. Yes, we agree. Here.
Hi, I'm Lauren Hart, and I lead a very large complex care center and have worked with more than 1,200 patients. And we add 5 to 20 patients a week, and it's very open-ended. So I see all the patients you see in addition to everyone who's uninsured. And what's waiting on the other side when we start really adding in outside of the insurance claims data is a repetition of the patterns you are seeing with the Medicaid and dual eligible population. There's 3 policy themes I wanted to ask you about what I see in the population. One thing that contributes to their complexity and instability is overprescribing of narcotics. So people had a disease, they legally were getting narcotics, and then their chronic pain isn't well managed, and they end up with issues that turn into addiction, and they frequently use the ED. A second is the ability to fire patients. In my market, dialysis units fire the patients. It's an unintended consequence of value-based payment arrangements. If people aren't following the rules, they can be fired by their primary care, dialysis, specialist. I wondered if you see that, and that's a policy opportunity, I think, to invest in. And then a third is people with felony records and their inability to get jobs. I have a subpopulation of patients, and I met with a man. He had more than 50 ED visits, and I talked with him thinking I was just going to be linking him to addiction treatment, and he said, "Lady, I'm 47 years old. I just got out of prison. No one will hire me. I can't get a place to live. The best place I can make a living is to repeatedly go to the ED where they'll prescribe me narcotics that I can sell. What are you going to do about that?" So felony records is a policy opportunity.
I think, well, let me do 40 seconds and we'll solve all of that. The narcotic issue is so real, and it is really it is no question. I mean, it would have been unthinkable when I go back 30, 40 years to think that prescriptions are now the major cause of addiction and the gateway for so many other things, and that's the first thing. In terms of the felony records, our largest single non-professional in-home support are self-directed personal care assistants. People choose their own personal care assistants for long-term supports. We ask everybody, do you want us to do a Corey check? Since it's their friend, their family, their granddaughter, niece, nephew, 85% don't want Corey checks. Why don't they want Corey checks? They don't want Corey checks because communities like North Springfield, Massachusetts, has 14% of that community on a year cycling through the county jail, usually a month, 2 months, 3 months, waiting adjudication of a charge. They can't make bail, or they do make bail and they have a record, and they can never get a job. So last year we funded a little under 1,000 full-time equivalent personal care assistant jobs as part of individualized care plans. And the vast majority of them had records. And it's maybe the last, and that's actually part of the potential redistribution job creation engine, taking ineffective Medicare and Medicaid dollars, going to hospitals and nursing homes, going to communities, and maybe being a part of the sustainability economy. So that's my contribution to that.
Thanks. I'm going to go back to just 2 prongs.
Yes.
So this morning we talked about the importance of bringing function into the discussion. I'm Rob Green from Dartmouth-Hitchcock Health, by the way. We talked about the importance of bringing function into the discussion from the patient's point of view, and I think especially functional outcomes that are important to people, which helps us bring things again to the consumer or patient's point of view. A lot of the projects that we're talking about are emphasizing the cost savings part of increasing value. So and I've done that for many years, so I've been in the same boat. But it makes me wonder if we should also be thinking about the positive health generation of value, increasing and maintaining function. And there are obviously some policy and issues there and how to monetize that. There's one stakeholder I don't really see represented that well in the room, which are the employers. They have their high-need patients with very similar needs and issues. So I think there's an opportunity for National Academy of Medicine in this series of projects to bring in both those types of viewpoints. How can we do better jobs on functional outcomes that are important to the patients, and bring in the employer stakeholders with their points of view and needs. I'd be interested in any of your comments on that. Thanks.
What about one response?
Well, first, with them in the room, I'd certainly suggest taking a look at the work that BPC has done with their CEO Council and sort of being able to help answer some of these questions. I'd also, there's some really interesting questions being raised by the Vitality Institute and asking, should there be almost an America's Healthiest Employer or a health index? Should that be part of a company's annual SEC filings or financial disclosures? So again, it does sort of raise some provocative questions about what is the link between people's health and the financial performance of a company. I'd say for us, we have seen, when we first started deploying these care coordination models and requiring the employers who were our customers to pay those claims, they were not all on board. And the work that I'd have to do from a data perspective is sort of separate which employers and therefore which benefit codes shouldn't be included in data sets. That's changed a lot over the years, and it's really hard now to find employers that don't want to be part of paying for this. So I think certainly there's a growing recognition on behalf of employers, particularly now because they're that much more engaged in paying for a lot of this. And I think I'd stop there.
So we have, all right, I'm going to do a time check. We have a few minutes left and a few folks here. So we're going to do here in the middle. We'll try to get these five we'll probably take them in and then answer them as a group. So we'll listen, take good notes, and then make summative statements. I think I'm going to try that, see if we can do it.
My name is Ellen Makar. I'm a registered nurse and a senior policy advisor for the Office of the National Coordinator of Health IT, currently on detail at AHRQ. My question is about Health IT. There was a question earlier, but I think it deserves a little more of your time. What I'd like to know is, based on the recent EHR 2020 report by AMIA, our interoperability roadmap that ONC produced, as well as the report to Congress about information blocking, how easy or difficult is it for you to do your job with the current health IT situation? And what do you see as research opportunities in that area?
Great. Hold that thought.
Good, I guess I'll piggyback on that one. My name is Jessica Bartell. I'm an internal medicine physician, and I'm a lead of population health at Epic. And my question is, we've talked earlier today about the inadequacy of claims data to fully understand patients and risk stratify them. And we've also talked about going to the patient and how important it is to get an understanding of them from the horse's mouth, if you will. And so I wondered what specific data we need from patients in order to best understand their needs, how we can standardize those assessments and reassessments over time so that we can feed that into the work that you're doing to drive the good work that's being done.
So that feeds right into my question or for the panel. Iora Health has slammed the existing EHR system, saying that it was developed primarily for coding and to maximize reimbursement. Anything having to do with focusing on a realigned primary care system is not part of the existing EHR. 39% of physicians would not recommend their current EHR system to others, and the dissatisfaction with EHRs has gone up from 25% to 37%. So I wonder what the panelists and other people think about that, because if it's about the patient and engineering primary care, the EHR focused in that particular area is essential.
Hi, Trissa Torres with the Institute for Healthcare Improvement. I just wanted to highlight again what Rebecca Ramsey was talking about in terms of investing in community-based organizations for the peer workers. And I liked that in many reasons. One is because I think the peer support has so much strength and so much we can learn also from the peer providers interfacing with the provider community, but also what that means in terms of investing in our community assets and really redirecting resources from healthcare into the community. And so if anybody had any additional comments on that, that'd be fantastic.
I'm Josh Rubin. I'm with the University of Michigan Medical School. I'm also with the group called the Learning Health Community and on the board of the Joseph H. Cantor Family Foundation. I'll focus on this concept called the learning health system. A theme I've heard a lot today is learning from patients, and there are at least two different ways that have come up from that. One is starting with sort of a Dr. Brenner kind of approach, is just listening and bringing together panels and bringing patients like Jeremy into the room to listen, and faster cures has even proposed that there may be a science to this, a science to patient input. Margaret Anderson has proposed that. The other, which we had a very passionate engineer speak about, is this sort of big data analytics, which feeds into this concept that this group developed, the Institute of Medicine developed this idea of the learning health system. They've published something like 16 or 18 different volumes on it over since 2007, under Michael's leadership a lot. But how do you bring this idea of learning from patients by learning from every experience from every patient, which is starting to be digitally captured? And how do you bring those two different ideas together, and how do you start to integrate this into what you're thinking about this kind of learning from the patient's experiences?
Okay, panel, these will be your summative. We got a lot there. So if you each take one of those, we've got some around interoperability, EHR, data, right? Who wants that one? Raise your hand. Go first. There you go.
I think the question over here was something like, how difficult is it to do your work in the current environment with EHRs not always interoperable, et cetera? And, the answer to that is difficult. I think, we had to create, our own web-based registry system to track the work of our health resilience specialists, because we're an Epic community, and the Epic versions that we have don't do good registry-based process measure productivity type care management tracking. They do fine at clinical data and narrative notes, et cetera, but our version didn't have that kind of tracking ability, and we had a lot of reporting we had to do to CMS because we were getting $17.3 million. That system is still operating. Our community actually loves it, and so we now have people who are working in Epic and in this system that we created that we're offering for free because it helps coordinate care, but that's not ideal. The other thing that's come on the horizon in Oregon and also is in Washington State is which I think is going to be a great asset to our community, is something called EDI, which is the Emergency Department Information Exchange. And this system is going to allow really good coordination between the ERs and the primary care clinics and the payers. And so when people are admitted to the ER, we're getting care plans that are being submitted both from primary care and ERs into that system, and then we can get, we can have that information securely transferred by a bunch of different modes, and that's being implemented statewide. So in the next year, we'll have a success story. But it's all challenging. 42 CFR makes it really difficult with our population, not being able to share substance abuse treatment information. I don't know. We need help.
Any other, or we can
I'll just
declare victory and end.
I'll just say ditto, and particularly the irrationality of the mental health, as we severed the head from the body. I'd say ditto, and we really are siloed in mental health issues around communication and medical, and that's That's where I would go first. It's a horrific situation.
I am fascinated by the concept of patient-reported outcomes, and if it's possible, separating them from patient-generated outcomes, things that maybe don't have to be validated by a clinician but are measurable by some other thing. I think our financial incentives for our value-based incentive design, sort of outside of the PCMH program, is based on a number of steps, one of which is completing a health risk assessment, right? And as a clinician, we know that, blood pressure, cholesterol, fasting plasma glucose, tobacco status, that really gives you that pretty good picture of health. Or health as some people measure it. How you translate all of these wearables and trackers and other things that people do every day to those measures, and how do you quantify that, or some would say monetize that, so you can award the appropriate financial incentives to this many Fitbit points versus this many Garmin points or Map My Run points. I think it's something that I don't know the answer to, but I think it's something that we're really interested in. I don't know if as a payer we'll ever be able to sort of, come up with that currency exchange, or if we're just going to have to rely on the hard actual measure themselves. But there has to be a way to do some sort of sense-making of all of this so that we can then communicate to people what the value of this actually is. That's something I'm just interested in without really having an answer to.
Great. Let's thank the panel for a great presentation.